Hello, this is Dr. Gary Rose. In this lecture, I will review the state of the science of harm reduction. Harm reduction arrived in the United States in the mid-1990s as yet another challenge to the extant American dispositional disease model of addiction and the public policy focus on, quote, use reduction, or the promotion of abstinence in those at risk. Over the last 25 years, the harm reduction movement has transformed the manner in which we engage with alcohol and drug misusers. Although relatively new to the US, harm reduction is absolutely consistent with the long-standing American investment in pragmatism and the pragmatic theory of truth. Alan Marlatt, a cutting-edge alcoholism researcher from the University of Washington, was instrumental in bringing harm reduction to the United States. Marlatt had a very interesting career, always at the forefront of the growing developments in the field of alcohol and drug use problems. In the early 1970s, he studied the impact of psychological expectancies on the intoxication experience using simulated bar labs on the University of Washington campus. In the early 80s, he spearheaded work on relapse prevention, and his cognitive behavioral theory of relapse prevention still stands as the seminal work on the subject. Next, he developed BASIC, B-A-S-C, a brief intervention for alcohol use reduction for college students. In the early 1990s, he became the first major American psychologist to write about the benefits of embracing a harm reduction approach to alcohol and drug use reduction. Towards the end of his career and his life, Marlatt died of metastatic cancer around 2010. He endorsed yet another cutting-edge perspective on substance use theory and treatment, behavioral economics. With regard to harm reduction, in his 1993 paper, Marlatt noted that we teach people the basics of safe driving, and we use our public health system to teach and support safe sex. Harm reduction extends these preventative perspectives to safe drinking, and also to safer use of other intoxicants. There's a long and storied history of harm reduction interventions in the UK and in Europe. For example, prescription heroin has been available in the UK for almost 100 years, given to bona fide street heroin addicts. The center of modern harm reduction, however, resides in the Netherlands and dates to the early 1970s. The culture of the Netherlands supports the a priori rights to personal choice and self-determination, especially with regard to lifestyle activities. Social and political policies focus on public health and safety rather than the legislation of morality. It is because of this that sex work is legal in the Netherlands, and the red light districts are well lit and well policed. While sex work is legal, there are strict guidelines regarding the health maintenance of sex workers with mandated health checks, etc. The policy focus is on the safety of sex workers and their clients, not on the control of personal sexual behavior. It was in this cultural context that the cannabis laws were reevaluated in the 1970s. Research indicated that most of the harm associated with cannabis use came not from the weed, but from the social context within which cannabis was being used. The criminal consequences with frequent incarceration actually induced greater harm than did the drug use per se. The much vaunted gateway theory, wherein the use of low-risk drugs supposedly leads to the use of high-risk drugs, was demonstrated to be a function of the cannabis user's necessary acquaintance with drug dealers, purveyors of both cannabis and high-risk drugs, and the ease with which one could go from product A, cannabis, to product B, opioids, etc. As a function of these and other sets of facts, the Dutch government changed the cannabis laws, decriminalizing most cannabis use and licensing the now famous coffee shops to dispense cannabis products to the end user. Although these moves now seem ho-hum, in the early 1970s, these were radical policies, anathema to the US war on drugs, the drugs is bad for you principles and policies of the US. As a consequence of these changes, the population percentage who used cannabis increased, but the per capita rate of cannabis-associated harm decreased markedly. This is the trade-off. Methadone by bus. What followed were various harm reduction interventions geared to the needs of IV drug users. Interestingly, in the Netherlands, IV drug users are not a stigmatized and marginalized minority group. They vote. They have a political action committee called the Junkie Bond. It is in this context of political influence that public policies changed. One such policy was the methadone bus. In Amsterdam, for example, the methadone maintenance programs come to the addicts via buses. Staffing the bus, in addition to the methadone nurse, are childcare workers, plumbers, electricians, etc. These folks are not there to coddle the addicts, quote unquote. Rather, they are there to engage with the drug users and to be helpful in a low threshold manner. The assertion is this: if we can help an addict today with a plumbing problem, then perhaps next week that person will reach out to us for help with health issues, childcare issues, or perhaps even a discussion about drug treatment. This is a prototypic harm reduction intervention. Start where the client is at, rather than where you would like them to end up. As a multi-layered approach to public and individual health, harm reduction is about reducing the health risks associated with drug use or other high-risk behaviors. It starts with accepting that the individual may not be ready, willing, or able to terminate the high-risk behavior, a radical idea for the confrontation of denial U.S. addictions establishment of the 1930s through the 2000s. Marlatt had his work cut out for him. The first harm reduction conference in North America took place in 1996. It was located in Toronto because the professional and political environment of the US did not condone harm reduction as an alternative to abstinence in 96. How did Marlatt balance harm reduction with abstinence? How did he bring together the abstinence and harm reduction folks, who, by the way, were as polarized as are the current right and left political wings? He did it in part with this figure. Rather than to assert that harm reduction was an alternative to abstinence, he indicated that abstinence would still remain as the gold standard of recovery and that harm reduction goals would serve as interim measures of success en route to abstinence. This was an elegant solution to what had heretofore been seen to be a black and white distinction. What followed into the first years of this century was a radical reformation of the nature of alcohol and drug use treatment in the US. Policies and treatment interventions changed, outcome measures were revised, and there was a major outflux of treatment staff who could not abide by non-abstinent goals and outcomes, and a consequent influx of a new generation of substance use professionals. It was both a tense and a very exciting time to be involved with substance abuse treatment in this country. Afghan Farming, 2006. Harm reduction comes in all forms and occurs at all levels of intervention. In 2006, the Afghan farmers were growing the poppy, supplying 80% of the world's opium. Consequent to a well-funded diversionary program, in 2008, the principal crop was cannabis. In what ways did this encompass the principles of harm reduction at the level of international policy? Consider the differential harm associated with opiates versus cannabis products. By promoting a change in crop, the United States was attempting to reduce on a macro level the harm associated with illicit drug use. However, by 2010, the preferred crop had returned to the poppy. Why? Consider the economics of the illicit drug trade. Imagine how much greater the value of a kilo of opium or morphine versus a kilo of weed. Considering that the opportunity costs associated with the export and distribution are relatively constant, only a failed capitalist would opt to export cannabis over opium. Here again, we see the manner in which economics often trumps other issues with regard to the illicit drug trade. A bit more successful has been this other macro level harm reduction intervention, mostly because there are as many or more American chocoholics as there are cocaine users. Crack cocaine laws. The federal mandated sentencing laws, adopted following the mandated laws established in New York during the governorship of Nelson Rockefeller, the Rockefeller laws, stand as an enduring problem as a US policy. Why were these laws problematic, and their revision just in the very recent past a form of macro level harm reduction? As mentioned during our discussion of cocaine, there was and continues to be ethnographic differences in the choice of cocaine hydrochloride, powdered cocaine, versus crack cocaine, with inner city, principally brown and black individuals opting for crack and more privileged Caucasian users, opting for powder, in great part due to price and availability. The original iteration of federal sentencing guidelines mandated a much more severe penalty for the casual crack user or small-time distributor versus the similar user and small-time distributor of cocaine powder. This, when combined with the 3 strikes and you're out rule, has resulted in thousands of crack users in prison for long periods of time. As the Dutch learned in the 1970s, this yielded a situation wherein the harm associated with the criminal penalty was far worse than the harm associated with the drug use per se. Recent changes in the sentencing guidelines have attempted to mitigate this discrepancy. However, the changes are too little and too late. Harm reduction circa November 3rd, 2020. Oregon decriminalizes the possession of all illicit drugs for personal use. Will the harm reduction benefit outweigh the public safety problems that will likely ensue? One doubts if the $100 civil fine is enough to induce people to accept treatment over the fine, as the cost of the use is below what behavioral economists call P-max, the price point that must be achieved to induce a change in choice. More about this when we discuss behavioral economics. Community level interventions. These are all forms of harm reduction at the community level. One of the most effective interventions to reduce college drinking is to engage with fraternities and sororities regarding perceived norms of partying. If one can reduce the collective belief about how much one must drink to get a good buzz, harm reduces for the whole community of students. Many colleges provide buses to transport students from campus to the downtown drinking areas to reduce alcohol-related driving incidences and the amount of vomit in the backseat of Uber sedans. Bar rooms that are partitioned into relatively small areas reduce incidents of violence, as do varying the bar closing hours, a standard in London and other UK cities. Shatterproof beer and booze bottles are another form of harm reduction, as they reduce the severity of harm associated with barroom brawls, particularly in Wales. I have first discussed these macro level harm reduction interventions, those at the level of laws and public policies, to counter the misperception that harm reduction is always focused on reducing the harm for this one individual over here. That being said, there clearly are many harm reduction interventions that are geared towards the needs of the particular drug user. The familiar drug works kit for the IV drug user, IVDU, is depicted here, with clean products for cooking and injecting. Needle exchange programs have now been around since the late 1990s, offering free clean needles to IVDUs who often cannot afford to purchase them at the local CVS. The fact that these are needle exchanges is important because clean needles are exchanged for dirty ones, thus reducing the harm to the IV drug user as well as to the kids and locals who might inadvertently step on a dirty needle in the park. By the way, the community acceptance of the needle exchange programs was, shall we say, a bit iffy back in the day. For example, the Boston needle exchange van was attacked by a mob of bat-wielding citizens, including the local selectmen, when it first started to park in Charlestown, Massachusetts, back around 2002. The Narcan Inhaler was the first widely available overdose protection device, followed by other forms of Narcan delivery, including the Evzio intramuscular injector. As previously mentioned, these devices were initially, by limits of law, only distributed for personal use. Obviously, if one is in an opioid overdose, one cannot self-inject. As harm reduction devices, these really are ways to keep your mates from dying, with, one hopes, the favor reciprocated. Another interesting harm reduction intervention was the reformulation of oxycodone to make it much more difficult to crush, cook, and inject this long-acting formulation of oxycodone.
Button up your overcoat when the wind is free. Take good care of yourself, you belong to me. Eat an apple every day.
Condoms for teens. Condoms for teens and all others is a harm reduction intervention not without controversy. Of course, the abstinence-only folks assert that this simply encourages the teens to do the dirty dance. The harm reduction folks acknowledge that teens have been dancing between the sheets since the invention of adolescence, and the condoms simply promote remaining healthy and infant-free to dance another day. A very recent individual-oriented harm reduction intervention is the prescription of antiretroviral drugs, HIV treatment, to HIV-negative IV drug users. For a number of years, HIV-negative sexual partners of HIV-positive folks have been given antiretrovirals to reduce the risk of getting the infection, which the ARVs do well. Given that IV drug users are at greater risk of getting the infection, the availability of antiretrovirals for this population, independent of with whom they have sex, is a very powerful and important harm reduction intervention. From a harm reduction perspective, the 21-year drinking age has not been without controversy. Although there are oodles of evidence that the change from 18 to 21 has been accompanied by a marked decrease in alcohol-related injury, many, if not most, college administrators are on the side of reducing the drinking age to 18. Why? They assert that the fact that most drinking age students are status offenders, in other words, it's illegal, reduces their ability to have open dialogues, for example, alcohol use education programs, with these students. Harm reduction occurs at all levels of intervention, from the micro level of the individual to the macro level of politics, laws, and social policies. Whether you're focusing on drinking and drugging education, access and availability to inhalers, or providing drug assay services that allows somebody, the end user, to know what they are about to ingest, or focusing on community interventions, Greek norm modifications, opening up midnight basketball courts at night as an alternative to spending the night drinking and driving the campus bus service, or at a macro level of social and political policy, licensing supervised shooting galleries like they have in Vancouver, and we're trying to get in Boston, modifying criminal laws, decriminalization, as we've seen recently in Portland. These are all harm reduction interventions at very different levels. They all have the same goal of reducing the amount of harm associated with the use and perhaps misuse of intoxicants. Harm reduction versus use reduction. Use reduction, the old and still in some ways standard approach to focusing on promoting abstinence, decreasing use, typically through supply side interventions, reducing supply, and criminalization. Harm reduction, the new model. There are many ways in which the newer harm reduction approach differs from the older, more established use reduction approach. Low threshold to access treatment, low threshold interventions versus high threshold interventions. The old use reduction interventions where you had to commit to abstinence even before you could walk in the door of the treatment center. Marlatt observed that back in 1993, that we're accessing only 20% of the people at best who need our services because we make it much too hard for them to walk in the door of our treatment centers. A public health focus versus a criminal justice focused model. When we talk now about decriminalizing the police, we're really talking about, or defunding the police, we're really talking about moving social services out of criminal justice into social services. Normalization of drug use versus stigmatization and marginalization of the drug user. Tolerance for some use versus tolerance only for abstinence, zero tolerance. Top-down approach where the policies and the procedures and what's available gets dictated at the highest levels of government, rather than bottom-up approach, starting with focus groups, by assessing the needs of the individuals. The addicts in the Netherlands who assert the need for the methadone bus to come to them rather than them to come to the methadone clinic. It's a bottom-up approach. The focus on working with the end users, collaboration, rather than dictating, the focus of a power sharing rather than a top-down kind of intervention. And the assertion that treatment services need to be ever-changing, need to be flexible, need to be pragmatic rather than rigid. 30 days in the woods, in the treatment center, 90 and 90. Commitment to abstinence, detoxification before treatment starts, et cetera, et cetera. Of greatest importance in this chart are the items that are highlighted in red. The normalization of drug use, the destigmatization of the drug user, reducing the threshold, reducing how difficult it is, what it takes, the level of motivation it takes during preparation to start the process of change, and the focus on pragmatism, absolutely essential and encapsulated by the harm reduction approach. Let's take a look at the opioid crisis from the triadic perspective of the public health model: agent, host, and environment. What is causing the opioid crisis? Here are some initial thoughts on the subject, and there are many more. The bullets in red reflect factors that are open to harm reduction interventions. What's causing the opioid crisis? Well, certainly the agent, the pharmaceuticals, these opioids that so effectively hijack the midbrain system. The availability of very, very high potency and dangerous fentanyl and fentanyl co-products. The agent, the fact that street heroin, street drugs, can be made up of heroin, of fentanyl, of rat poisoning, of all sorts of things. The end user simply never really knows what's in the agent that they're purchasing. Host issues. The typical polysubstance abuser who presents with all sorts of comorbidities and vulnerabilities, psychological, related to economics, lack of job training, lack of education, disrupted home environments, etc., etc. Knowledge deficits. We do not teach people enough about the drugs of intoxication to help them be educated consumers. An educated consumer is our best customer. A slogan from a clothing warehouse purveyor. Existential hopelessness. There's a reason that there's such a positive correlation between communities of disruption, communities of poverty, and opioid overdoses. These are all host issues. Environmental issues and public policy issues. The fact that addicts and drug users IV drug users are so marginalized and stigmatized within the US. The fact that there are so few harm reduction programs, whether they're shooting galleries or other things that are funded and licensed. Environmental, social, public policy interventions, issues, the rejection in the United States summarily of non-abstinent outcomes, the rejection in the United States of the reverse gateway opioids to cannabis outcome that's now being anecdotally reported as very, very successful. Few alternative positive reinforcers. APR is a concept that we'll address when we talk about behavioral economics. The issues highlighted in red are absolutely open to harm reduction interventions. The availability of drug assay programs, drug analysis programs, and drug analysis kits, so you know what you're about to take and you can make a considered decision. Drug and alcohol education programs in the middle schools, in the high schools, in the colleges, not just alcohol, but opioid, cannabis education, and so forth. The increased flexibility, the reduction of the threshold with regard to opioid interventions and treatments to accept that not only methadone users, but other opioid users may opt for, be more comfortable with, prefer non-abstinent outcomes. What can we do? These are some of the things that we can do. Some of the potential solutions. Tolerance of recreational use. The decriminalization in Oregon is certainly an example of this. It may or may not be in the best interest of the greater population. Destigmatization, again, normalization. You can normalize something, demarginalize it without necessarily condoning it. Opioid use education. There are indeed lower risk ways to use opioids versus higher risk ways. Certainly getting your drugs analyzed would be one lower risk way. We need to teach people about that. Licensing shooting galleries where people can shoot drugs under the supervision of licensed medical professionals, clean supplies. And even though we've got a lot of Narcan, we don't have enough of it available on the street. How do we engage in effective harm reduction conversations with the drug and alcohol user? Fortunately, there are lots of commonalities between harm reduction principles and the strategies of MI, and that's what you see listed here. Both harm reduction and MI are client-centered. They're focused on appreciating this individual's unique connection to the target of behavior change, the high-risk drug use. Both harm reduction and MI meet the patient, meet the client where they're at. They respect that readiness to change occurs on a continuum and that it's an ever-changing process. They both eschew concepts of denial, of resistance. They both look into the interaction between the user and the provider, the user and the program, the user and the policy, and readiness to change. Both appreciate that there is value in the status quo. There are pros to staying the same as much as there are cons to staying the same, and pros and cons to change. The focus, the agenda, the goals are established collaboratively with the client taking the lead. The concept of dual expertise, that the practitioner has a set of expertise and so does the client, and there needs to be a meeting of the mind. Client-focused agenda setting, offering more than one option for change, flexibility, pragmatism regarding change. As Marlatt asserted in his very famous figure, abstinence always stands as an option, a powerful option for drug use change, but there are all sorts of other changes, viable goals along the way, whether or not one ever moves towards abstinence. And this is all done in a very collaborative, empowering, MI-spirited way. So harm reduction as a set of principles, motivational interviewing is a set of therapeutic interventions that go very much hand in hand. One starting point is to employ the oh-so-ever handy decisional matrix in the service of a harm reduction conversation. The classic good, not so good MI intervention is a great example of harm reduction in action. What we do in the good, not so good is we focus principally, only, exclusively on the maintaining my current behavior column of the decisional matrix. Given that you are committed at this point in time to maintain your drug use, to maintain your alcohol use, let's look at both sides of that decision, both sides of that commitment. What's good about that? What are the benefits? What's not so good about that? With the focus on helping the person differentiate the benefits from the costs and perhaps engage in a conversation with us about how to maintain the costs while reducing the benefits. After having demonstrated curiosity in the spectrum of outcomes associated with continued drug use, the good and the not so good, the MI practitioner offers an eliciting question or two. This allows correct collaboration regarding a harm reduction focus or goal, or perhaps no change at all if the client is not ready for change. Harm reduction has fundamentally changed the conversational bandwidth of substance misuse conversations, and MI provides an array of effective tools for these expanded conversations, especially for those clients least ready to engage in conversations about abstinence or marked change. So with this, we end this brief introduction to harm reduction and the harm reduction motivational interviewing connection.